I wanted to thank the hospital and everyone for coming this evening. It's certainly a pleasure. I think it's fun to talk about food while we're eating food. Some of the information that I'm going to discuss tonight is controversial because it really challenges some of the fundamental principles of nutrition that we hold to be true. But I think the information is important because it represents a paradigm shift in our thinking. So tonight's lecture is really discussing better nutrition and the problem with dietary carbohydrates. But it also answers the question, why and how has nutrition changed significantly in the last 100 years? And unfortunately, this change has been detrimental to our health and also costly as we spend more at the doctor's office treating the complications of obesity. So we're going to be looking for some answers tonight, and we're going to turn to the science of nutrition and hopefully redefine healthy nutrition. So my disclosure, I occasionally get paid to speak, not this evening, but that's okay. It's my pleasure to be here. I recruit patients from speaking either directly when I lecture to the community or indirectly from physician referrals. And I think this is important because I'm not promoting any expensive medical therapies. It's just better health through better nutrition. So the outline, we're going to discuss the history and the politics of nutrition. We're going to look at the science of nutrition and hopefully present you with some evidence. We'd like to rewrite the nutritional guidelines, and we're going to summarize and hopefully come up with an action plan. So, some terminology. We have this twin epidemic that we call diabesity, and it tells us that there's a relationship between the two conditions, diabetes and obesity. And that relationship is actually a progression of a condition known as insulin resistance. And we'll talk more about that. But the point is that the chance of developing diabetes is more common than you would think. So some statistics. We happen to be one of the fattest countries in the world, if not the fattest. And unfortunately, we have to blame our refined and processed foods that we consume. We export this around the world, and this is unfortunately contributing to obesity worldwide. So some of the statistics, I think the important point here is when you realize that 60% of our adult population are overweight and obese in our country, and also that a third of the children in our country are presently overweight and obese, I think it becomes a significant issue because it's affecting so many people in our country. Now, we all know Colorado is the thinnest state in the country, and we're proud of that. But when we look at overweight statistics, we have an issue in this state as well. If this isn't concerning enough to you, let's look at a timeline of obesity trends. And basically, this goes back to 1960. This is data from NHANES, directly from the CDC, the National Health Survey. And as you can see, in 1960 up to about 1977, obesity rates are under 15%. And then something happens in 1977, the rates start to skyrocket. And so on this slide from 2010, we now see obesity rates have continued to reach now about 34 or 35%, and it's continuing to climb. I didn't have a graph of this one, but also during this time period, 1977 on, obesity rates have tripled in children and adolescents. So if we don't do something about this, it's predicted that 42% of us will be obese by 2030, and 33% of us will be diabetic by 2050. And this really represents a progression of insulin resistance in our population. So some historical perspective. Traditionally, we blame behavior for obesity, that we are gluttons and sloths, like our little cat friend here. We eat too much and we exercise too little. In fact, the scientists are convinced, they're so convinced that it is a behavioral disorder that they use the science of energy balance, or the first law of thermodynamics, to explain this. And they convinced the health insurance industry, particularly in 1965 when we see Medicare and Medicaid developed by the government. they say, we're not going to pay for this because this is a behavioral disorder, obesity. And what a mistake that is. But the bottom line here, it's your fault as an individual. You have to fix this problem on your own because the healthcare community doesn't know how to address it, and they're not going to help you with it because they're not going to get paid for it. And what do we get as a result of this? Some entrepreneurs say, hey, we're going to step to the plate and come up with the solution. And we get the billion-dollar weight loss industry, Weight Watchers the first, then Nutrisystem, Jenny Craig. And this is what we call an invention. And the invention of the low-fat, low-calorie diet industry. And they tell us that carbohydrates are safe to consume. This continues. It's always fun when we see movie stars, sports figures out there promoting these foods. And I don't particularly like that myself. But my colleagues and I, when we look at this, this was the type of nutrition that didn't exist prior to 1965. And it's an invention, and the question is, was there good science to back it up? And so that's why my colleagues and I refer to these as just more examples of fad diets. And the next question is, if these are working and this is the solution, why are we still fat? So let's look at the nutritional timeline. And it's really a political timeline because it is the USDA who is really in the business of selling food that are trying to tell us that the food that we're supposed to buy from them is healthy and safe. And we call that self-policing, like the fox in charge of the hen house. Trust me, just do what I say. So that's a problem. But this nutritional timeline really starts post-World War II. And there's basically two scientific principles. The first principle is that of the Lipid Hypothesis that develops in the 1950s. And we're all familiar with this. And that is that consuming saturated fat in the diet will elevate cholesterol and will lead to heart disease, stroke, atherosclerosis, and so forth. And so a scientist by the name of Ancel Keys actually makes this notion popular. And he wants to go out and prove or demonstrate a relationship. And he actually does several studies in the 1950s. They're impressive for his time because they were observational studies looking at large populations. And two of the studies, one called the 6-country study, and then later the 7-country study, appeared to demonstrate a dose-response relationship to consumption of saturated fat and heart disease. Unfortunately, he was heavily criticized back in the 1950s in Geneva at a World Health Organization meeting where other scientists had pointed out that he had cherry-picked the data. So the 6-country study actually started as a 22-country study. And what he did was he eliminated 16 countries from that particular study. Now it's interesting, so he showed that absolute association. If he included the 22 countries, it actually would have shown an association, but a very, very weak association. So he was criticized for that. But here's the problem. These were observational studies. And the point is that correlation does not equal causality. In observational studies, when you're looking at food trials and so forth, they're actually sometimes all we have because it's so difficult to do feeding trials, actually randomized controlled trials looking at nutrition. And this is the next best thing. But you have to be critical. The problem with these studies is they're observational studies only. They raise hypothesis. They're not controlling variables. There's too many confounding variables in these particular studies. But those are the problems that we had with these studies, and yet the United States, federal government, and the scientists in our country said, this makes sense. We're going to support this. So the second scientific principle we've already talked about, and that is energy balance and the first law of thermodynamics, that if we eat fat, we're going to get fat. So we need to eat less and we need to exercise more. We have to avoid caloric-dense fatty foods. The problem here is that this is, unfortunately, a very simple explanation. It is really metabolism, it's hormones, and we're going to talk about this, and a derangement of hormones that determine why we get fat. So this is just too simple of an explanation. And it basically became a snowball effect. Actually, I should back up. Ansel Keys in 1961 was written up in Time magazine that he had the solution to heart disease. But then we get the McGovern Select Committee, Senate Committee, from 1968 to 1977. And they basically come up with some nutritional guidelines based on these principles. And if you noticed on the first slide, we were talking about 1970. Here it starts, okay, 1977. So, shortly after 77, in 1980, we get the first USDA official dietary guidelines for Americans. And I actually wanted to go through this. So this is actually the first guideline that I was able to pull from the CDC website. And let's talk about it. So it says to eat a variety of foods. That sounds good. Maintain ideal body weight. I like that. Avoid too much fat, saturated fat, and cholesterol. Okay, there's the recommendation to cut back on fat in the diet. Eat foods with adequate starch and fiber. Let's eat more carbohydrate. Avoid too much sugar. We're going to come back to that in 1 minute. Avoid too much sodium. Okay, perhaps some people even argue that sodium's not quite as bad as we thought it was these days. And watch your alcohol consumption. But now let's go back to the sugar recommendation. If we dig deeper into the pamphlet, it says, and I quote, "Contrary to widespread opinion, too much sugar in your diet does not seem to cause diabetes. There is also no convincing evidence that sugar causes heart attack or blood vessel diseases." So I hope most of you disagree with those statements. I certainly do. But the problem is, this is the fundamental principles of nutrition in our country that really began 1977 to 1980. And it's built upon it. And it's very hard for the FDA to step back and say, oh, we were wrong. They never do that. So in 1980, there were several people that really objected to this. One individual by the name of Phil Handler was the president of the National Academy of Sciences. And he called this a vast nutritional experiment for which there was very little scientific evidence. But they didn't listen or support these scientists that didn't support the popular trends. And so from 1980 on, we get dietary guidelines that are revised every 5 years. And it basically turns into the food pyramid. We get the first food pyramid in 1992. In 2005, it's revised. 2011, we get My Plate. Problem is, it's the same old tired advice that we've been hearing for 30 years. And that is, let's eat less saturated fat. Let's reduce calories. Let's replace saturated fat with polyunsaturated vegetable oils. Let's eat more carbohydrates, including starches, and yes, sugars. Because the food industry realized that if you don't put fat in foods, people aren't going to like it. They need to make it palatable. So they've actually put a ton of sugar, including high fructose corn syrup, which came about 1975, 1985. Again, right around the date where we see obesity start to rise. And they're basically telling us, you know what? We want you to eat more of those food commodities because they're abundant, and trust us, it's safe. So the argument here is that this is all based on weak evidence, providing us with the wrong tools. And the tools tell us if you need to lose weight, you're supposed to eat low-fat, low-calorie foods, basically starve. And in my experience, I think in most people's experience, long-term over a life, it's very difficult to restrict calories in your diet. So perhaps that's a reason it's not working. So just a little bit more about the evidence. In other words, the lipid hypothesis. And so we want to ask the question, does saturated fat cause heart disease? This is what Ansel Keys has told us. And so we've actually looked at the literature over the past 70 years. And this is a great website where it basically summarizes some of the evidence. And we have both observational and clinical trials. And just to summarize, of the observational studies, there were two well-done meta-analyses. One was a Cochrane review And it involved 350,000 subjects. And basically the answer to the question is no, there's no causal relationship. Then we look at some more meta-analysis. There's actually 3 meta-analysis on clinical trials, one of which was the Cochrane Review that said no. There was one meta-analysis but said yes, it's problematic, and one of the issues was confounding variables, and they actually double-dipped on the data. So I don't see where saturated fat has any causal relationship to heart disease, although that's what they taught me in medical school. Didn't make sense to me. This makes more sense to me. So we'll look at the agriculture industry. And agriculture changes for us about 250 years ago with the Industrial Revolution. And it's basically just kind of been a progression, especially in the last 100 years. And so basically it has become the production of food commodities that they're trying to sell us. And these food commodities are inexpensive. They're relatively simple to produce. And we can look at these. So basically it's grains, corn, wheat, rice, starchy vegetable like potatoes, and the sugar. First we get sugar from cane and beet, and then in 1978, high fructose corn syrup. And that's the predominant sugar in our sugar sweetened beverages. And there's been a lot of press lately about the problem with high fructose corn syrup. And then soybean. Soybean is another commodity of choice. It may be the protein, but it's the protein or whey protein we see, but we also see soybean oil in virtually everything. All the salad dressings that we eat, and we'll talk a little, we may actually have problems with some of the proteins or the flavonoids in soybean, as well as there's issues about the proteins, the gliadin and the glutenin in the wheat, that it's actually been changed over the last 30 years, that the quality of the protein in the wheat is now addicting. We eat it and it makes us hungrier. And then industrial vegetable oils, which really come from seeds. And again, we see vegetable oils in our diet because Ansel Keys told us to replace saturated fat with polyunsaturated fat. But we have problems with vegetable oils. They're manufactured, they turn rancid, they oxidize, and they're really one step away from trans fats if you think about it. And then more of these whole foods, the animals and other plants, are relatively expensive. So of course the food industry wants us to eat these simply produced plant-based foods. So the farmers are incentive with farm bills. This may have been a good thing way back in the 50s when we saw, the 40s and 50s when we saw the farm bill. But now they have such an abundance of corn and wheat that they don't know what to do with it. Also the idea to increase yields. So the bushels of corn and wheat produced today is almost twice what it was back 30, 40 years ago. And they've now, they start by actually cross-germinating the seeds to selectively enhance these particular grains. And now in the 1970s, they develop genetically modified organisms, and that really takes off in the 1990s, where they've now, again, found ways to genetically change these foods to enhance the flavor, the size, to make the food resistant to pesticides. And by the way, they also make the pesticides. And we really have to thank companies like Monsanto and DuPont, who may have forever changed the foods that we consume today. And the problem is that they really haven't studied the health benefits of these types of foods. They said, well, it's corn and wheat. So our argument is we don't like corn and wheat anyway. So another way to look at this is how our ancestors ate before agriculture. And if you look at the Paleolithic Man, which had spanned over a 2.5 million period of time, they were hunter-gatherers, they were opportunistic, and what they tended to eat were whole foods, clean foods, unprocessed foods. They had no way to process foods. And these foods tend to have very little carbohydrate in it. Now, how do we know this? So from radioisotope studies of the fossils, we can determine what they ate. And also, looking at the fossils, we can determine that they were healthy. Now, everyone asks, well, they didn't live as long. Okay, so they may have problems with infant mortality, infection, injury, but to be honest, we don't really know how long they lived. But when we look at the bones, they were thick. They carried large muscles, and that suggests that they were rather healthy. But the foods that they ate were, the majority of foods were animals, including fish, and on a seasonal basis, they would eat veggies, fruits, nuts. About 500,000 years ago, we discovered fire, and we're now able to cook our meat. We're actually able to now eat tubers and roots, like potatoes, which are basically poisonous unless you cook them. Everything changes in the Neolithic. So as we come out of the Stone Age into this Neolithic period of time, the hunter-gatherers now settle and they start farming. And what did they cultivate? They cultivate the grains, and also they domesticate animals for dairy. So there's an argument with this Paleolithic movement that you've probably heard about in the last several years, that we should cut out grains and dairy in our diet. Now, I think these are guidelines or a blueprint for how we should possibly eat. So I think there's a good point about the grains. As you'll see, we don't really have significant issues with dairy. The point here is that our ancestors ate these whole, clean foods that were unprocessed. And it's really modern civilization that has changed the foods that we eat, in particular, more and more carbohydrates in our diet as time goes on. So now back to reality. So the food manufacturers, they are in the business of selling food for profit. And they're looking for inexpensive raw materials, and they turn to these food commodities and the grains. And so they're trying to make the food tasty, addicting, actually cost-effective for the public. And you'll actually see it's a combination of sugar, vegetable oil, and soy. And that's a typical American diet, and unfortunately it's not a healthy diet, and we'll talk about it. But they further refine and process foods, and they make even more money. And so, looking at some of the major food manufacturers, Pepsi Company just doesn't sell sugar-sweetened beverages with high fructose corn syrup anymore. They sell a lot of unhealthy other processed foods. Nestle, that's an international company, is probably the biggest manufacturer here. And yeah, you can attack the fast food industry, but the pockets go much deeper into these food manufacturers. We like this idea, the deceptive advertising, where they try to make a health claim to promote the foods that they're producing. And my latest favorite is 7 whole grains on a mission. Anybody know? Kashi. So we take a look at Kashi. They're bars, and it's basically carbohydrate, sugar, vegetable oils, and chemicals that I can't even pronounce. And it looks more like a candy bar. So we really have to thank Kellogg, who actually bought up Kashi, I think in 2001. I don't know what that mission is. It certainly doesn't seem to have anything to do with health, according to myself. So we have to ask the people at Kellogg's what that mission is. So the other idea is that we have the food industry funding politicians to support programs for these unhealthy foods that we're consuming. And again, don't think for a minute that these people have any interest in your health. It's about selling food. And I just should back up, and the point is that civilization, we wouldn't be here if it wasn't for corn, wheat, and potato. The point is that civilizations thousands of years ago probably created these foods out of necessity. And the question is, today, in the 21st century, are these foods healthy for us? So let's look at the cost of health care. And again, we're world leaders. Congratulations to us, not a good thing. But we spend almost twice per capita in this slide here than other countries, or 16% of the GDP versus 8 to 10% in other countries. And look at this magical date, 1978 to 80. So there may be a lot of factors in here, but I think obesity is playing into this, as well as healthcare gets regulated or deregulated around 1980. But I certainly also think about a point of diminishing returns. What are we getting for our money? But how does obesity play into it? The statistics change from year to year. So in 2012, Cornell had just said that we spend $190 billion, or 20% of national health care expenses. Last year it was 9%. And so my argument is that this is a gross underestimation. There's flaw in the study. The study can only tease out obesity. They can't include overweight. They can't obtain data. And so the point is that they're looking at this all wrong. The question is, what is the cost of treating chronic disease like hypertension, atherosclerosis, diabetes, heart disease? If you add them all up, they really are caused by obesity and overweight, and that may be a better representation of obesity healthcare costs, significantly more than 20%. I would say probably 60 or 70% of healthcare expenditure. So what do we get for all this money? We get our wonderful healthcare system, Medicare Medicaid, that is managed by the federal government in 1965. And what's important is that they set the guidelines for the industry, both public and private. And the program says that we're going to pay for the treatment of illness and disease only. Obesity, not a medical condition. We're not going to pay for it. Now guess what? It just changed in 2012. Medicare said, okay, we're going to focus on this, and we're going to pay primary care doctors to counsel. The first problem is that this recommendation came out from the Preventive Task Force, who again views obesity as a behavioral disorder. That's the wrong organization. We'd like to argue that this is a chronic metabolic disease that we're talking about. But the problem here is most primary care doctors weren't trained about nutrition. They're not even sure what to do with this. It's very strict, the criteria. So it is a step in the right direction. So perhaps this will have some positive outcome. But the other problem we have is this whole healthcare system is a reactive system. And we're going to run out of money unless we change that. And the other thing is, as we all know, as doctors sitting here today, that treating the obesity complications is profitable. And so the argument is that money and my time is probably better spent addressing the cause, obesity and overweight. So this is where we have become. It might be evolution up to a certain point, but within the last 30 years, we have now artificially manufactured and changed nutrition. So now we're obese, we're overweight, we're sick, and this patient has to go to the doctor and be treated for all the medical conditions, polypharmacy, medical procedures, you name it, just to keep him going. And yes, we prolong life. Medicine's a wonderful thing, but the argument is something's wrong. How about we prevent disease in the first place? And it's really nutrition has changed things for us. And so we can see that the nutritional experiment hasn't worked. And unfortunately, I think the healthcare industry are perhaps just as guilty as the rest of us, because we're traditionally providing the same nutritional advice that everyone else is doing, and yet the argument is that nutritional advice is actually making us sick, not making us healthy. So that's where fat reform is healthcare reform. And if we can address obesity, we're going to save billions of dollars treating the complications. Those of us most interested in public health or the health of our patients are the ones that should be regulating the food industry, not this self-regulation, self-policing. The other concept where nutrition is center stage in the delivery of healthcare, right now it's way out there. And I know doctors are frustrated, patients can't lose weight, but that's because we're providing them with the wrong tools. So if we understand nutrition, we put it center stage, we teach our young physicians about nutrition and how to perform programs on patients, it might make a difference. We want to redefine healthy nutrition, and we're going to look at the science in a minute here. We want to re-educate healthcare professionals and the population about the problem of dietary carbohydrates and why fat in the diet may not be such a bad thing after all. So this is kind of the scientific part of the lecture. And so what we'd like to discuss with you are the macronutrients, and that all macronutrients are not alike. And the argument is that carbohydrates are fattening and inflammatory, and fats and proteins are not. And we're going to talk about obesity as a chronic metabolic disease and some conditions, insulin resistance and inflammation. So let's talk about insulin. So there's several hormones that regulate energy and the storage of energy in our body. Insulin is probably the primary hormone or signal. So we talk about it, people are familiar with it. And so insulin is most sensitive to carbohydrates and dietary carbohydrates. We refer to it as the primary fuel. Why is this so? Because it's a simple fuel. The body most relies on this particular form of energy. And we can think of carbohydrate consumption as turning on the insulin switch. When we reduce carbohydrates in the diet, it turns off the insulin, or it lowers the level of insulin. Dietary proteins and fats are different. I think the previous lecture talked about we have to process proteins through mTOR pathway. We have to process fats as well to get energy out of it. And we call it a secondary fuel. As well as proteins and fats, it's essential. You basically cannot live without protein and fats in your diet. You can live without dietary carbohydrates. There's nothing essential about it. Protein and fats have a minimal effect on insulin compared to carbohydrate. Protein has more of an effect on the insulin, but fat virtually has very little effect on insulin. And that's the difference between the two macronutrients right there. When you eat carbohydrates, it sends metabolism into overdrive. The body was designed to tolerate protein and fats, and yet we've told everybody to eat more carbohydrates because they're good for us. So then we have the insulin receptors, and they're on both lean body tissue and fat tissue, and they respond to the insulin signal that there's food energy in the bloodstream, and that energy gets absorbed by lean body tissue. If there's extra energy, especially carbohydrates, it gets stored, it gets converted to triglyceride in the liver and then stored as body fat. And of course, body fat is this unlimited storage space. So as we keep eating more and more, we're going to store more and more. So normally, as insulin rises, it'll suppress appetite, and it's a classic negative feedback pathway that our endocrinologists will tell us about in the room. When we reduce insulin, either by not eating or eating a meal that's void of carbohydrate, that's a signal to promote the release of energy and the utilization of stored energy in our body. And this is really basic physiology. So, insulin resistance. Imagine years and years of carbohydrate overload. We're going to require more and more insulin. We're going to gain weight. We're going to build up body fat. And this just continues. More insulin produced from carbohydrate consumption, more weight gain. Eventually, there's so much circulating insulin that the insulin receptors everywhere in the body become actually resistant, and they don't respond to the insulin message. So what happens? The pancreas has to produce more insulin. And as this cycle goes on and on, eventually the beta cells in the pancreas create an abnormal response where they're initially producing even more insulin than they should, but eventually they'll die off and you're left treating patients with insulin. But this is the vicious insulin cycle that we talk about. Hunger is a rather large component here, and this is a disease of insulin overload. A little bit of insulin, a little bit of these protein signals are a good thing. A lot of it are a very bad thing. So hunger and appetite. Insulin resistance makes us hungry. So as the fat cells increase in our body and double in size, it turns out that most of the insulin and most of the energy are feeding right into the fat cells. And we're depleting the rest of the body, the lean body tissue of food energy. And this may be an explanation why we have no energy and we're always hungry. If we look at the central hunger centers of the brain, both the hypothalamus and the nucleus accumbens, we see that the fluctuating insulin levels and carbohydrate levels will actually have a pathologic effect where they eventually stimulate appetite rather than suppressing appetite. We can get insulin resistance directly at the hypothalamus or by other hormones such as leptin. And a great way to describe insulin resistance or leptin resistance in the brain is you eat, insulin tries to signal the brain doesn't get the signal. So guess what? You're still hungry. What do? You keep eating. So that's a big problem. So we lose central signals, and the only signals are peripheral from a swollen stomach. And I described that at this carbohydrate fullness where you're so bloated that you can't move. So I think this is an explanation where we blame metabolism. It's not a condition of behavior. Some more about regulation of food intake. So there's all kinds of hormones that we're just beginning to learn about. And basically there's 4 feeding organs, as it were, that release hormones. So we have the adipocytes, the fat cells that release leptin and many other hormones. We have the pancreas releasing insulin, amylin, polypeptide P. The stomach is releasing ghrelin. And we have other hormones from the gut. We have visceral afferents or vagal afferents also, but PYY, GLP-1, and other hormones. And basically, the problem is that we develop resistance. So these protein signals are not working properly. Well, it turns out that these signals do a lot of other things. So when we talk about leptin, it may have more to do with thermogenesis, regulation of body temperature, or basal metabolic rate. And through its action, it may have adverse effects on the immune system, premature aging, chronic disease, dementia, cancer, libido, fertility. It's interesting, we're just learning. And in the same way, insulin has similar potential negative effects as we develop resistance. There's another pathway through insulin like growth factor 1, and I know that the oncologists are quite concerned about this. This is actually produced in the liver. That's not on this slide, but the more IGF, it basically tells cells to feed off of the insulin signals. So that's a bad thing, contributing to cancer, premature aging. So a whole other way to look at this is a disease of inflammation or a disease of the adipocyte or the fat cell itself. And so as the fat cells increase and double and triple in size, it releases toxic substances. So most of these protein signals or hormones, cytokines, adipokines are inflammatory. We see increased free fatty acids in the bloodstream. We see oxidation of lipid and cholesterol, and all this is atherogenic. This is bad for us. And it further fuels insulin resistance and beta cell dysfunction. And so we can think of this as a disease of energy overload or energy storage disease. And it's really inflammation and a derangement of metabolism. And again, it all relates back to dietary carbohydrates, not dietary fats. And we think of obesity as a chronic metabolic disease. And so this is another way just to describe this. So we have the fat cells in the center of the universe, and it's releasing all these inflammatory substances that lead to chronic diseases that we see in modern society. And every time I look at this slide, I want to add something to this. I realize it doesn't have liver disease in here and fatty liver, that kind of stuff. But I know that the oncologists are really concerned about this when they see the release of things like IGF-1, plasminogen activator inhibitor 1, tumor necrosis factor, IL-6, all these things promote cancer growth. So that's why we call this a chronic metabolic disease. So the treatment. We have to realize that we're treating a progressive condition from overweight to type 2 diabetes. Prediabetes or metabolic syndrome is a subset of this. And the simple tools, by the way, this is Stephanie, one of my favorite patients. She's been mine for a long time. And so one of the best tools is just to weigh the patient, do a body fat, body mass index. We, of course, get a history. We do a lot of OGTs or GTTs in the office. When I first started doing this 10 years ago, I was surprised at the findings of these OGTs and the abnormal results. Nowadays, I'm not so surprised. We want to measure metabolic markers of inflammation and take your pick: hemoglobin A1C, C-peptide, insulin, CRP, thyroid. It goes on and on. One comment about cholesterol. Cholesterol testing is useful, but for me, I realize that cholesterol is a marker for heart disease. I do not believe that cholesterol causes heart disease. I believe that inflammation causes heart disease. And that's a profound statement. So insulin treatment. Here's the fun stuff. The food is the medicine. If we remove the fuel, we're going to treat this condition. We just reduce dietary carbohydrates in the diet, and we would just reverse everything I just talked about. We turn off the insulin switch. That promotes the release of stored energy from fat cells. It improves insulin resistance. It improves beta cell function. It ultimately controls hunger and appetite. And we actually, people kind of go through carbohydrate withdrawal when they're first doing this, and we support them through this period of time as the body says, hey, there's no more dietary carbohydrates coming in, we better start burning body fat for energy. And once the body figures this out, it's perhaps metabolically challenging, the energy starts to come up, their appetite's controlled, they're losing weight, and they feel well. But again, just to realize that I now understand that carbohydrates are non-essential. It's an optional fuel, and we eat too much of them. So, it's a simple message. If we could tell our patients to cut out refined and processed foods, particularly from corn, wheat, and sugar, we will be doing so much good to our patients. So, dietary protein. I don't want to imply that this is a meat fest. In a relative sense, you're going to eat a little bit more protein. In general, across the board, people don't change their protein consumption that much. But we also try to support vegetarians, particularly if we call them lacto-vegetarians, where they eat dairy. A pure vegan, if they do it for ethical reasons, that's fine. But we have problems with vegan diets. But dietary protein is essential, and it's healthy. Fats and cholesterol. Simple point about cholesterol. Over the years, that we have found that dietary cholesterol doesn't do much to your blood cholesterol levels. And our cells are made of cholesterol. It's a good thing. We're supposed to eat cholesterol. Dietary fat, same thing. It's essential. It's healthy. It's caloric dense and filling. That's a good thing. If you fill people up quick, they're not going to eat less. Again, it's not inflammatory. It's not atherogenic. There's one exception, and this is the standard American diet, where we eat these refined and processed foods or combinations that tend to be refined carbohydrates and or sugars with vegetable oils, and the protein of choice, it can be soy or whey. And the problem is carbohydrate is acting as the catalyst, and it's doubly bad to be consuming fat with carbohydrate. But it's not because of the fat, it's because of the carbohydrate. So medication. So we realize that this is a disease of metabolism. So we're looking for medications that address the metabolism and treat the resistance. And we use these medications, which are predominantly type 2 diabetic medications, off-label and pre-diabetic, and also overweight patients, and we've had success. So the metformin's been around for a long time, and some of these GLP-1 medications like Byetta, Victoza, Bydureon, Similac is actually slightly different medication, but we've had success using these. There's also a role for some of these traditional appetite suppressants. There's new ones coming out on the market, because it turns out if you're not very insulin resistant, it's a challenge for weight loss. So we try to do anything and everything we can to help our patients lose weight. But our experience is the more insulin resistant you are, the more you respond to this type of diet. There's future drugs, there's over-the-counter drugs. The fun part is that we can treat the comorbidities with nutrition. Nutrition is again center stage. So it's not that there's a role for medication, but the first tool doesn't have to be throwing medication at them. You can make a contract, lose weight, and we'll stop medication. If you don't lose weight, we're going to keep you on medication. That's a good tool. And then there's gastric bypass surgery. And the point here is that you have to be very careful and selective in the patients that go to gastric bypass because you're really altering normal anatomy. And I think that they deserve a good trial of a low-carb diet before they resort to this type of procedure. And that's bacon. So this is what we talk to our patients about. We want them to eat real foods. We focus on the carbohydrate content of food. We talk about glycemic index. We can count grams of carbohydrate. We want to avoid the high glycemic foods, the processed foods. So we tell them to eat no grains, or we say healthy no grain diet. So corn, wheat, and rice, we really don't find any role for them in our diet. Starchy vegetables. Again, soy is the vegetable oil or the protein of choice. And my argument is, if I had a choice for a protein or a natural fat, I don't want to eat soy. We used to think soy was the superfood. And I put beans and other legumes because soy, of course, is a legume, and then there's some other concerns about the proteins in legumes as well. So what we tell patients, a couple of boiled beans in a salad, that's not going to be a problem. So we wanted them to eat low glycemic foods, whole foods, unprocessed foods. So all the animal proteins. I think an egg is a superfood. It basically has all the fixings for life in it, and that the best part's the yolk that has all the vitamins, mineral, nutrients. Green leafy vegetables, spinach, kale, broccoli, cauliflower, asparagus. The difference is we get to put some natural fats like butter on it. We don't have to be careful about the fat that we put on. Fibrous fruits, berries are the best example, but you have to be careful because they're genetically modifying everything, where they're making them more sweet, they're making them larger. These mammoth strawberries are they look like apples. They're crazy. Nuts, low glycemic dairy, so cheese and cream. Again, I don't have a problem with dairy, but milk, the more liquid in a dairy product, the more sugar, so we want to avoid milk. Eat healthy fats. They're low glycemic, they're not fattening, they're not inflammatory. We're talking about saturated fats, monounsaturated fats, omega-3, which is actually a polyunsaturated. They tend to contain the fat-soluble vitamins, A, D. E isn't really abundant in animal foods. K and B12, actually, you can only get B12 from animals. D, you might get it from mushrooms, but vitamin D you get predominantly from animal-based foods. And we're talking about these fats, these healthy fats. Coconut oil. I always take a tablespoon of coconut oil before I lecture. I think it makes me think better. Maybe not. Olive oil, avocado, butter, animal fat, the fish oils. Again, they're caloric dense. They fill you up quickly. We want to avoid industrial vegetable oils. So understand, before 1912, the predominant fats that we ate were butter, lard. Around this time, they were able to produce vegetable oils from seeds. And for whatever reason, I think it had a lot to do with money. Perhaps the availability and the cost, refrigeration for the natural fats, the butter and the animal fats, they had to switch over. And so this is the invention of vegetable oils, and also, guess what, trans fats, or basically Crisco in 1912 replaced butter, and now we all agree that there's problems with that. And again, vegetable oils turn rancid. They put a ton of vitamin E in it to prevent it from breaking down. You overcook it, and it turns into trans fat. So my argument is there was never a problem with the natural fats. So why are we eating these vegetable oils? Again, the government told us that we should. And there's also a lot of omega-6, so we want to eat more omega-3, which we get from other sources besides these vegetable oils. So we call this low-carb, high-fat diet. And the benefit is it controls appetite, it promotes weight loss, we get enhanced fat burning during exercise, and quantity calories and the portions are not the focus with patients. We tell you to eat. The way to lose weight and to be healthy is to eat and to eat the right foods. We let metabolism take care of appetite. Calories do count, but the point is we've demonstrated over 30 years that you tell patients to sacrifice over and over again, it's not going to work. So we can compare diets. So basically, we have the very low-fat, high-carb, or the low-calorie diet, like the Pritikin and the Ornish diet. And on the other extreme, we have the very low-carb and the high-fat diet, so it's less than 10% of calories from carbohydrate. And high-fat, we're pushing, it can be 60 to 70% of calories from fat. And we call this low-carb, high-fat, and there's nothing new about it. Basically, in the 1860s, William Banting wrote his letter on corpulence, and this is how most patients lost weight when they went to the doctor's office before the 1950s until the USDA got involved. So we can compare low-carb and paleo diets as well. And so they're very similar. I think the message is that the food quality is very important. Again, the paleo diet says no dairy, and most of them say butter's fine. They actually express some concerns that mother's milk is enzymatically and hormonally quite active. But in terms of helping patients lose weight, if you increase the fat content of food, of which dairy has a lot, you're going to help your patients that way. So the Paleolithic diet actually, so it's maybe less fat, more protein, slightly more carbohydrates. I think Paleolithic is for people that want to enhance their performance. They don't have quite as much weight to lose, but people even lose weight on Paleolithic diets. So what diets are healthy and safe? And so over the last 10 plus years, we have dozens of well-done randomized controlled trials looking at head-to-head comparison of low-carb versus low-fat diets. And what the studies show us is that we get a greater weight loss, we get an improvement in cardiometabolic markers, blood sugars also improve. The ADA, actually in 2008, has recognized the benefit of low-carb diets, although it's a weak support. Now they say that they support it up to 2 years because we don't have any data beyond that. But when you look at the metabolic markers, you can see that there's improvement. So let's look at one of the studies here, and we're almost at the end. This was the Stanford A to Z weight loss study. 2007, they looked at 300 women. They randomized them into 4 different diet groups, and on the low-carb side, we have Atkins, and on the low-fat side, we have Ornish. And basically what's most important to look at is the triangles on the bottom is the Atkins diet. So at 6 months and at 12 months, they lost most weight on the Atkins diet. Now, I actually had the chance to meet Chris Gardner about a month ago here in Denver when he was lecturing, and the guy is just brilliant. And he's just so critical about his research and trying to make these well-done studies. And he pointed out how difficult it is to put humans into cages and tell them you have to eat this. And that's the problem with all feeding trials over the last 70 years. And you have to look at them critically. Were they well done? Were they not well done? And it even comes down to food logs and food diaries. And you look at it and you can see how terrible it was done over the past 70 years. But the other thing that's interesting about Chris Gardner is he is biased. He's a vegetarian for ethical reasons. And yet these were his findings. So we can look at metabolic markers, and this is a complicated slide. You can avoid the numbers in the parentheses, but just look to the left here. And basically, just look at the Atkins compared to the Ornish. The other ones are Zone and Learn diet, but the statistical significance really is between Ornish and Atkins. And basically what happens on the Atkins diet is all the lipid profiles improve. So LDL cholesterol may be the one exception. It actually might have gone up slightly at the end of the 12-month trial. HDL went way up, the good cholesterol. Triglycerides went way down by 29%. The non-HDL cholesterol went down by 5%. Now, if we look at the Ornish diet, what happens? Everything went down. So LDL went down. Perhaps that's a good thing. HDL didn't do much. It initially went down, but then it went, it didn't change at all. And you compare that to Atkins, where it went up by 5% almost. Triglycerides dropped not as much as Atkins, and the non-HDL kind of similar. But if I had a choice between my lipid profile, I would choose the Atkins profile. So let's look at advanced lipid testing. So now there's an argument that calculated LDL cholesterol is meaningless. And I think I agree with that. I think it's a good tool in my office. We do the traditional lipid testing. It's a good screening test. But if you see LDLs high, you want to move on to advanced lipid testing. And so there's now 3 labs that do this: Berkeley Heart Lab, NMR Liposcience, the VAP cholesterol test. And rather than show you the studies, I thought I would give you a patient example. But what we find on low-carb, high-fat diets, the LDL subclass, or the LDL particle size, is favorable in virtually every patient on low-carb, high-fat diets that are able to lose weight. Another favorable marker, which is a very significant marker, and I think the other lecturers talked about this, is HDL cholesterol increases, triglycerides decrease. And this ratio may be a more significant marker for the oxidative potential of cholesterol molecules. So there's other markers: ApoB, LDL particles, LPA, which is an independent risk factor, and there's genetic testing. So this patient happens to be Dr. Jeff Gerber, that I just did my blood work last month. And so I've been eating this way for 10 plus years. I've had some personal experience, weight loss experience. And what you can see is basically, if you're not familiar with this is the Berkeley Heart Lab. The numbers up top are traditional testing. So total cholesterol 234, LDL-C calculated 142, that's in the red zone. HDL, triglyceride, awesome. Now we go down to advanced testing, and basically Berkeley breaks it down into 7 subclasses. It's crazy, but these are the bad subclasses. And basically what this confers is a healthy pattern A large particle, okay, in every respect. ApoB, I can describe ApoB as basically the bad bus that carries all the bad cholesterol molecules. And so this is now believed to be a more accurate determination versus LDL-C. So mine's in the intermediate zone. LPA, which is another independent risk factor, is quite low. It's in the healthy green zone. I would never put a patient like this on a statin. The oxidative potential is very minimal. Some might disagree, but I think it's good to present it in this way. I use advanced testing to measure the benefit of nutrition and diet versus other docs that are using this to put patients on medication. There's a role for medication, but my focus is different. So some patients, real quick. What time is it? 5 Did we start late? No? Okay. So I'm running over. Marcia came in, and she had multiple medical problems. She had immune systems conditions. She had taken tryptophan back in the 90s. She didn't die from it. She was on statins. She was on acid pump inhibitors, all kinds of allergy medication. And we actually had to go at it for quite some time, but she eventually got focused and went on a strict paleo diet. And over a period of time, she lost 70 pounds, 27% loss of her body weight. And this is her recently, and she's maintained that. And it's still a challenge for her. And I have the markers just to show. You'll have to take my word. They all get better, okay? David Mendoza is diabetic for 10 years. We met over the internet. He was my first patient to put on Byetta, or one of these GLP-1 analogs. And he was on metformin. He's a great guy, but he's also stubborn. He doesn't want to take medication. So basically over 2 years, he loses 50% of his weight. He loses half his body weight. And this is him now. He was in the restaurant. Now he enjoys hiking, and not bad for using this diabetic medication to help him lose weight. And he basically has, off of all medication, he has no evidence of type 2 diabetes. Patrick almost met the criteria for metabolic syndrome. His comment after he lost 45 pounds is, Dr. Gerber, I didn't know that I could lose weight by eating. Okay. And this is another patient, Eric. I'm not going to go into him, but it's just another little story about advanced lipid testing. So if you want to read more, there's tons of stuff out there. Gary Taubes is a personal friend, and he's just brilliant, and he's basically looked at the science, or lack of it, over the years and pointed out the problems with it. But Eric Westman, Jeff Folick, Steve Finney, these are just brilliant people. I'm not the only one looking at nutrition this way nowadays. So this is nutrition in the new millennium for the next 1,000 years, if we can go on that long. We want to redefine healthy nutrition, less refined and processed foods from carbohydrates and vegetable oils, more whole foods, including natural fats, plants and animal sources. We want new federal guidelines, and that's a hard one to make change on that one. We want to regulate the food industry. We want to redefine the delivery of healthcare where nutrition is center stage, and ultimately to control the cost of healthcare. And so good food is good medicine. And it's fun in the social media these days. We get a lot of support. I have patients come in. We get to very easily talk to the experts. And so we're a small group fighting against the big gorilla, the federal government. And again, they're people, just hardworking people trying to do their jobs, and it's just very hard to make change. So it has to start from the bottom up, and I think that's a good place. So thanks for your time. A brief